For decades, hematologists and pathologists have really wrestled with this highly confusing diagnostic label, atypical CML. It sounded like it was just a mere variant of a well-known disease, but clinically, it behaved completely differently. So today, we're diving deep into a major shift in hemapathology in this explainer. We're looking at the newly defined World Health Organization 5th edition entity, myelodysplastic/myeloproliferative neoplasm with neutrophilia. Let's explore how modern molecular biology has just completely rewritten our understanding of this rare yet incredibly aggressive overlap neoplasm.
The WHO 5th edition explicitly emphasizes that this is a distinct overlap neoplasm, right? It is not just some quirky version of chronic myeloid leukemia. Keeping that old name, atypical CML, honestly created dangerous clinical confusion. By embracing the name MDS/MPN with neutrophilia, we're finally accurately reflecting its true underlying biology.
Okay, here's our roadmap for today. First, we'll cover redefining atypical CML. Second, the WHO 5 diagnostic criteria. Third, morphology and molecular genetics. Fourth, the differential diagnosis. And fifth, we'll wrap up with prognosis, minimal residual disease, and treatment algorithms.
All right, let's jump right into Section 1, Redefining Atypical CML, a necessary shift. Now, there is a stark biological juxtaposition here. Classical CML is defined by the BCR-ABL1 fusion, meaning it's driven by a very specific tyrosine kinase. And because of that, patients generally have an excellent response to TKIs. On the flip side, the disease we used to call atypical CML, it's completely BCR-ABL1 negative. There's no fusion gene, and therefore absolutely no routine benefit from TKIs. Implying that it would respond to similar treatments was, honestly, a fatal misconception.
So what exactly is it? Well, MDS/MPN with neutrophilia is a rare, clonal, hemopoietic stem cell disorder. It typically affects older adults, mostly males, usually between 65 and 75 years of age. And as a true overlap syndrome, it demonstrates two opposing forces simultaneously. First, you've got myeloproliferation, and that drives this massive, persistent neutrophilic leukocytosis. But right alongside that, you have myelodysplasia, meaning you get marked dysgranulopoiesis, the neutrophils just do not mature normally. And hovering over this entire clinical picture is a very high risk of transformation to acute myeloid leukemia, or AML.
Moving on to Section 2, WHO 5 diagnostic criteria. Diagnostic pillars.
The WHO lays out 5 absolute diagnostic pillars you need to hit. First up, persistent leukocytosis, specifically a white blood cell count of 13 × 10 to the 9th per liter or greater. Second, neutrophilic proliferation, where immature granulocytes, think myelocytes and promyelocytes, make up 10% or more of the leukocytes. Third, prominent dysgranulopoiesis. Fourth, your bone marrow blasts absolutely must be strictly under 20%. If they cross that line, you're dealing with AML. And fifth, the strict exclusion of other diseases. You just cannot make this diagnosis in a vacuum.
If we trace the pathogenesis timeline, this disease kicks off in a multipotent hematopoietic stem cell. It usually starts with an epigenetic founder mutation, most commonly ASXL1 or TET2. Then the cell picks up additional secondary signaling mutations, things like SETBP1 or ETNK1. And this 1-2 punch triggers runaway granulocytic expansion combined with that dysplastic maturation we talked about, which eventually culminates in full-blown AML progression for a lot of these patients.
Okay, Section 3, Morphology and Molecular Genetics, Cellular Evidence. When you actually look at a high-resolution peripheral blood smear for this disease, it is just chaotic. You're going to see absolute neutrophilia with a really prominent left shift. The neutrophils themselves just look fundamentally wrong. We're talking hypogranular forms, giant neutrophils, and pseudo-Pelger-Hewitt cells with abnormal nuclear lobation. But here is an incredibly crucial clue. There is minimal basophilia. Literally, if you see prominent basophilia, you need to stop, rethink your diagnosis, and look back toward classical CML.
Dropping down into the bone marrow itself, we find a markedly hypercellular environment that's just dominated by granulocytic hyperplasia and dysplastic granulopoiesis. Now, ancillary testing is key here. Cytochemistry will show MPO and Sudan black B positivity in the blasts, while flow cytometry is primarily used to quantify those blasts and formally exclude AML. As for the cytogenetics, you might see trisomy 8, deletion 20q, or monosomy 7. But frankly, a lot of patients have a completely normal karyotype. There isn't a single pathognomonic structural abnormality you can rely on here.
Now, looking at the molecular landscape,
While no single gene defines the disease, finding a SETBP1 or ETNK1 mutation strongly supports your diagnosis. ASXL1, on the other hand, indicates a particularly poor prognosis, while TET2 just acts as a common founder mutation. But crucially, pay close attention to CSF3R. These mutations are exceedingly rare in MDS/MPN-N, so if you do find one, it heavily favors a diagnosis of chronic neutrophilic leukemia instead.
Which brings us to Section 4, the differential diagnosis, exclude lookalikes. Let's compare MDS/MPN-N directly with classical CML. The most critical point here is the BCR/ABL1 fusion. It is literally the ultimate dividing line. In MDS/MPN-N, it is definitively negative. In classical CML, it's positive. Plus, classical CML features prominent basophilia and minimal dysplasia. MDS/MPN-N is the exact opposite of that, marked dysplasia with minimal basophilia.
Now, what about chronic neutrophilic leukemia, or CNL? Here, the CSF3R mutation is your big differentiator. It's common in CNL, but as we just mentioned, it's rare in MDS/MPNN. Furthermore, MDS/MPNN has 10% or more immature granulocytes in the blood, along with marked dysgranulopoiesis. CNL, conversely, usually has less than 10% immature forms and minimal dysplasia.
We also have to confidently exclude a few other suspects. Reactive neutrophilia from infections or inflammation, that's got to be ruled out. Those conditions completely lack persistent clonality and marked dysplasia. We also must exclude CMML, which is defined by a persistent monocytosis, not neutrophilia. And of course, we have to exclude AML, which is diagnosed the literal second blast levels hit that 20% threshold, or if specific AML-defining genetics are present. All right, our final segment, Section 5, Prognosis, MRD, and Treatment, Clinical Outcomes. 1 to 3, that is the grim median survival in years for patients diagnosed with MDS/MPN with neutrophilia. I want to just pause for a second to underscore the sheer severity of this neoplasm. Because it lacks a direct targeted therapy, like the TKIs we use in classical CML, the clinical outcomes here are incredibly challenging. 30 to 40, that is the alarming percentage of patients with this disease who will eventually transform into acute myeloid leukemia during their clinical course. It's an aggressive, progressive disorder that just relentlessly pushes the bone marrow toward total failure.
We do know that certain factors indicate a much worse outcome. Having a SETBP1 or ASXL1 mutation, a complex karyotype, increasing blasts, older age, or honestly just failing to achieve a hematologic response to initial therapies, all of these spell trouble. As for monitoring the disease, standard minimal residual disease, or MRD, well, it isn't formally standardized here like it is in other leukemias. Instead, clinicians really have to rely on a combination of routine CBCs, serial bone marrow morphology, and molecular tracking in selected patients just to watch for progression.
So how is it actually treated? The algorithm is progressive but unfortunately limited. Step 1, observation, is rarely appropriate because most patients are going to eventually require therapy. Step 2 is cytoreduction. Hydroxyurea is often your preferred agent here to manage symptomatic leukocytosis and splenomegaly. Step 3 involves hypomethylating agents like azacitidine or decitabine, though honestly, responses are usually not durable. Which brings us to Step 4, allogeneic hematopoietic stem cell transplantation. For younger, fit patients with high-risk disease, this remains the absolute only curative treatment available right now.
I want to leave you with this essential clinical pearl for anyone working in hematology. Always perform BCR-ABL1 testing first. The greatest diagnostic pitfall is confusing this rare, aggressive overlap neoplasm with classical CML. If you don't secure the exact molecular identity of the disease, you cannot offer the correct treatment path, and it forces us to ask a really provocative question. In an era of rapidly advancing precision medicine, how many other atypical diseases are currently hiding in plain sight, just waiting for the right molecular lens to finally reveal their true identity? Think about that as you review your next marrow case.